Welcome to Ortho Tutorials. This is a podcast that is dedicated to simplifying orthopedics for medical students and medical officers. My name is Ezekiel Oburu, and I am an orthopedic surgeon at the University of Nairobi. Our topic of today is femoral shaft fractures. Femoral shaft fractures have a bimodal distribution. The young patients usually present with these fractures after high energy trauma. With the elderly, it is usually a fall from a standing position, and it's because they may have either osteopenia or osteoporosis. The main mechanism of injury in our setup, that is Nairobi, Kenya, is a road traffic accident. And there's been a proliferation of border borders in our city, and therefore a number of these patients were either passengers in a border and were involved in a road traffic accident, or even some of them were pedestrians. But also we have a number of patients who present and they were in a motor vehicle and there was a road traffic accident in which they were involved in. The gold standard of treatment of femoral shaft fractures is an intermedullary nail, and this was after the introduction by Gerhard Kushner during the Second World War, when a number of the British prisoners of war returned to their country, and they had these intermedullary nails, and that really revolutionized the management of femoral shaft fractures. So how do these patients present, or what is the anatomy of their presentation? There is a characteristic deformity pattern with these patients that can be observed when you look at the X-ray. The proximal fragment is usually flexed, and this is due to the pull of the gluteus medius and the gluteus minimus on the greater trochanter, and it is usually abducted because of the iliopsoas on the lesser trochanter. What about the distal fragment? This is usually inverus because the adductors are pulling it, and it is in extension because of the gastrocnemius attaching to the distal aspect of the femur. What is the classification of these fractures? The classification is the Winquist classification, and really I wouldn't ask you to bother with this. And how do you evaluate these patients? Like all patients, especially with long bone fractures, don't forget the ATLS protocol, because usually it's high energy trauma, especially in a young person. So don't forget to do a good history and a physical examination. Remember that these fractures can have a significant blood loss, up to about 1,250 mils. So one must really do a proper evaluation of the patient and evaluate their circulation or cardiovascular system. They rarely present with peripheral nerve injuries, but it is important to do an evaluation of this. Examine the skin carefully to ensure that they don't have an open wound, as this can be easily missed. And remember, they may still have a compartment syndrome despite the fracture being open. Now, with regards to radiology, it's important to do full-length AP and lateral X-rays of the femur. Do not forget the joint above, because a number of these fractures may be associated with femoral neck fractures. The incidence is 3 to 10%. And sometimes in our A&Es or in our casualty department, what we do find is that patients have inadequate X-rays, and during fixation, you find that the surgeon discovers that actually this patient had a femoral neck fracture. This should not happen at all. In fact, before any surgery, the surgeon must ensure that they can adequately see the femoral neck or the hip joint. Remember also, these patients may have concomitant knee injuries. These are usually easy to diagnose after the patient has undergone surgery. When you have got a stable femur, you can see if the patient has got any ligamentous laxity, and probably in the future see if they have any associated medial or lateral meniscus injuries. So what is the management? Really, historically, we use traction, and sometimes in our setup, because of the reduced resources that we may have, patients may still be put on traction. Although I must argue that this really should be done for temporarily and should not be the definitive fixation. Traction is associated with bed sores, pain tract infections, malunion, especially in femoral shaft fractures, knee stiffness, muscle wasting, and increase in venous thromboembotic complications. So I think that traction should not be used, and it should only be used for temporary stabilization. The gold standard is intramedullary nailing. This obviously the advantage is minimal disruption of the biology of the fracture, and usually this can be done closed. Although sometimes it's not possible because where the surgeon is working or the hospital the patient is seen, image intensifier or fluoroscopy, or may not have traction in the form of a traction table. I think that it is important at least to do it open. I think that this is more advantageous than managing it with traction. Remember that I think it's important that patients get immediate stabilization, especially within the first 24 hours. What are the complications that may arise? Number one, a leg length discrepancy. Number two, non-union. Number three, malunion. Other things like infection, especially if the fracture is open, and heterotropic ossification, although this is rare. In summary, don't miss concomitant injuries, including ipsilateral femoral neck fractures. Many a surgeon will tell you that they have missed this in the past, and intramedullary nailing is the gold standard of treatment. Thank you very much. That is the end of our episode today.